Okay, so I have this was Clive again. Clive decided it would be a great thing for this CCAS meeting to look at the data from the country reports that we've been having over the last 10 years of CCAS. And of course, it was Clive's idea, but he assigned it to me. So, but it was really a great experience to go through the country reports, and it has been a great experience year by year as we've watched the evolution of country reports at CCAS. Andrea's locked me up. Okay, thank you.
There you go.
So I'm actually going to, because the title of the talk is a 10-year retrospective on capacity building, I'm actually going to look at the CCAS country presentations. And at the Caribbean MedLabs Foundation, we began to coordinate the country reports from 2008 at the Suriname meeting of CCAS. And I'll cover some aspects of that and really share some of the highlights and the examples of success stories that were shared at CCAS, in the CCAS country reports. I want to talk a little bit about the declarations that have come out of CCAS and also all the ongoing lab strengthening initiatives that have surrounded some of what has been happening at CCAS during the years. So the Caribbean, you've seen this map several times. The Caribbean is really a very spread out environment, a lot of countries separated by water and some by fairly large land masses. And we have sometimes been a little punished for having this environment, which we all love. But it sort of sends a message when your meeting location looks as this does, even though everybody's here. So this is one of our islands. I guess I can give a prize to the person who can tell me which one. And this is one of the mainland countries. I can tell you what this one is. This is Kaita Falls in Guyana. So our countries are really quite diverse is the point, you know. Topography differs a lot. You know, we have language differences sometimes, but we also have a lot of commonalities. And so CCAS has really been a way of bringing these countries together. So the country presentations have really included the CARICOM countries. So those, well, they were 14, now 15 countries of CARICOM, which includes Haiti. So all of the English-speaking Caribbean. The Dutch Caribbean islands have been represented in those country reports, St. Martin and St. Eustatius. They have not been here all the time, but they have been here and have presented their country reports. We have from the Spanish Caribbean, the Dominican Republic, and the British Overseas Territories, Bermuda, and Cayman Islands have also been at CCAS and presented. And the countries, so it's 21 countries have actually provided data through these country reports at various points in time throughout the history of this meeting. And each year, from 2008 to 2016, Barbados and St. Kitts and Nevis actually presented every single year. So we have data and presentations from those two countries for every single year of the CCAS meetings. Each year except 1 year, Bahamas and Jamaica presented, 1 year each, Bahamas and Jamaica. And then we have 7 or 8 years from the other 8 CARICOM countries. So it varies a little bit in terms of the data that we have from all of these countries within the Caribbean. And this actually goes back all the way to 2008. Wendy Kitson-Piggott, my colleague at the Caribbean MedLabs Foundation, actually set this as the remit to the country presentations when we began to do to coordinate the presentations, that they would celebrate the progress, identify gaps and barriers, define and agree on needs and recommendations for moving forward, agreeing targets for the future, and to collect and analyze and utilize data for advocacy for resources and continued support to the HIV programs. So that was really the intention behind these country reports. And they have continued in that vein as we've moved through the years. So these two slides, I have this one and another, which actually try to outline what were some of the things that we wanted to look at. Every country from the start has been presented on their demographics, their prevalence, HIV prevalence, but even there we've started to see some fine-tuning, and I will get into the details of that a little later. We had CD4 testing in countries. Most countries reported from 2008 that they were actually doing CD4 testing. And we had CD4 testing. I actually put here so that we would remember when it was 350, was anything below 350, anyone who was 350 or below treatment was started. These were the guidelines from WHO, less than 500, and then treat all. And we do have two countries that reported in 2016, bearing in mind that when countries report in 2016, they're actually reporting 2015 data. So two countries actually reported that they had already started and adopted treat all in 2015 when they made their reports in 2016. We had access to viral load testing locally or referral to LRU for the OECS countries that are too small. And for other countries in the region, they also access viral load. So we have some very small British overseas territories like Anguilla and St. Martin that access in French St. Martin, who actually have the capacity for that. So we have a number of networks that are operational. The LRU network with the OECS is the best known one, but we have others that are actually functioning within the region. Voluntary counseling and testing and provider-initiated testing. Well, we went from voluntary counseling and testing initially into provider-initiated testing. So rapid testing at sites. And PM to CT, from the first report in 2008, we had information about PM to CT. And eventually PM to CT, the prevention of mother-to-child transmission, has evolved into elimination of mother-to-child transmission. These elimination targets in 2015 and EMTCT validation actually began in 2016. So these are some of the highlights about what has been happening as we move forward through this process. ARV access, that was also reported, and again, a variable bag here, because in many cases, ARVs, while there was access, it was who was able to access, what level of access, and who was actually paying, because a lot of ARV access was actually financed by donors rather than by countries. So we have ARV access. So all the countries reported on ARV access. And then we began the treatment cascades later on in 2015 and 2016. Countries reported on their 2014 treatment cascade in 2015 and 2015 in 2016. So the treatment cascades were a later addition when treatment cascades became requirements. We also initiated laboratory indicator reporting. And at a CCAS meeting in 2011, actually, we agreed on what were the network indicators that we were actually going to be monitoring for the lab network. And we agreed turnaround time, proficiency testing, and surveillance reporting. And that agreement actually took place and was utilized as part of the Global Fund project that CMLF, the PANCAP Global Fund project that CMLF was implemented. So we actually utilized those indicators to monitor what was actually happening within the network. So 2012, we began the process of having country reports include monitoring of these indicators. National lab policy also entered the picture later on. In 2015, countries reported on what was happening with their national lab policies, and in 2016. And I will talk a bit more about that later on. I put in accreditation here because countries weren't really asked to report on this, but this was an important highlight, I think, that needed to be highlighted. Accreditation of the Lady Mead Reference Lab, which took place in 2009. And as a reference lab providing services to other countries in the region, this was an important step forward for the Lady Mead Reference Lab. And in 2013, the Barbados HIV Reference Lab actually achieved its accreditation. Sorry, Bahamas, sorry. The Bahamas HIV Reference Lab achieved accreditation. And both these labs have maintained their accreditation throughout. They have continued to maintain their accreditation. And CCAS declarations, and this was actually a first for CCAS in 2011. There was a CCAS declaration and another one in 2014, and we'll talk some about those later. So that gives you a little picture about, some of the kinds of things that countries were reporting on throughout the process of reporting on their country. I actually put a few slides here just to show us some of the data that has actually come from these country reports. And thanks to Wayne for helping me with pulling some of this data out. The HIV prevalence reported in the country reports varied, of course, as one would expect. But basically, 3% was the highest reported in Bahamas, and this was their 2007 figure, which was actually reported in 2008. So they reported 3%. Trinidad and Tobago reported a similar level of HIV infection prevalence. And Barbados, 2%. We saw Barbados dropping to 1.5% by 2015, when last they reported their data in 2016. They reported 1.5%. And you can see that some countries, like Haiti, reported the same level of HIV infection throughout. Guyana had a level of close to 2.5%. The countries, therefore, actually were able to report on their prevalence, overall prevalence. But what also entered the picture, and I just put these up to illustrate how they varied over time. The challenge we had, of course, in looking at the data, and this is by no means all the data, of course, every year they reported. The challenge we had was the continuity of the data and the way in which the data was reported each year. So that did create some challenges. In 2016, we actually got information about key populations. So people were reporting about what's happening in key populations. So for Haiti, for example, for MSM and for commercial sex workers, and in the Dominican Republic for MSM and trans. So you can see that these levels are quite different to the levels in the previous slide, where the highest level was actually 3%. So you can see how much higher these prevalence rates are. When we look at PMTCT testing, that was a very interesting exercise, because in fact, from the start, these figures are really what were reported in 2008. So countries were actually doing a fairly high level of testing for mother-to-child transmission, even as we began to collect data about this. So you can see that all the countries, with the exception of St. Kitts, were actually over 80%, even at the start. And in 2016, again, data not being reported by all the countries in the same way, so it was difficult to really come up with comparative data. I did pull data in between this, but I know that seeing it on the slide, you wouldn't really be able to see much if I actually put it all up. But the problem that we had really was the challenge of matching the data up by country as the data was presented. But this is one country that reported, and thinking about the people and how this program actually impacts on the babies is really important. And this particular country reported that 95% of their pregnant women are tested, and they actually gave figures for 2006-07. You see, we started in 2006 at 87%, went to 92 and about 91%. And the ARV coverage, very high, 98 to 100% of those mothers who were HIV positive, 98 to 100% of those. And that actually tells us why we are seeing that a number of countries in the Caribbean are actually able to aspire to elimination, because they began with a fairly high level of testing. They were giving ARVs, and so by pushing their system forward, they were actually, and some of them have actually been able to meet the elimination guidelines. I can't mention which ones those are at this point, but the Regional Validation Committee on which I sit actually met and agreed on some of this recently. So These are really important targets for countries to have reached at this point in time. We started, as I said, with HIV treatment cascades. Those entered the picture fairly late. In the last few years, we've been asking countries to present their treatment cascades. And I've just put up a couple of examples here. So we can see that countries, most of the countries have actually been calculating what's happening with their HIV, their persons living with HIV, their estimates of numbers of persons, those who are actually diagnosed, and in the case of Jamaica, they estimate 81% of persons know their status, and they are linking 73% to care. But when you look at viral suppression, it's down to 14%. So clearly we are losing in this area quite significantly in this particular chart. The results of the chart varied a lot, and I know that Cesar presented quite a few of those this morning, and we had quite a few of these yesterday. But I think it's really important for us to recognize that all countries have actually been presenting their treatment cascades over the last few years at the CCAS meeting. And what is interesting is that in some cases, treatment cascades are actually, in the case of COIN in the Dominican Republic, they've actually developed treatment cascades and separated them for different key populations. So they've actually had female sex workers, MSM, the drug users, trans, and migrants. So they've actually been able to create their treatment cascades for the different groups. And so you can see that female sex workers actually, they're having fairly good success as compared to what's happening with trans and migrants. But it's really important, I think, for us to evolve. This is clearly going to be another step in how we try to move other countries forward in terms of analyzing their data so they can actually see what's happening with the different populations. Of course, this is done by COIN, who really work very directly with key populations, and so they are able to actually create and access this kind of information. And then I wanted to share with you some examples of program successes, and I chose a fairly random group of but I thought important success stories because there were many. There were really, really a lot, far too many for us to go through here. But in 2008, as early as 2008, Bahamas was testing, doing their testing and treatment program was fully government funded. So this was really a great, achievement for the Bahamas. The Guyana shared a patient monitoring system for public and private patients, and I can still remember that particular, initiative, where they generate monthly reports and they can actually deal with looking at how they're actually monitoring their patients in terms of ensuring that they're actually getting all the tests that they should, that they're actually being seen when they should, and they are actually having their drugs and so on. And the challenges they had were including the private physicians and poor public patient compliance because, again, stigma and discrimination was one of the things that, again, was highlighted as early as 2008 when they presented this data. In 2008 also, Haiti reported that they had a national EQA program for HIV testing using the dry tube specimen. So as far back as 2008, I know that Patrice talked about the fact that they're actually doing this quality assurance network with the labs, and the public health lab runs this EQA, national EQA program. In 2016, they reported on the patient linkage data from 52 sites, and they were actually trying to reach patients who might otherwise have been lost to follow-up. And more than 45% of the patients returned to care after the tracing intervention. So they actually had field tracing. I know Patrice talked a bit about that as well, but this was reported by Haiti. So another really excellent program success that was shared at CCAS. And I think that illustrates the importance of CCAS in terms of sharing success. Yesterday, Clive mentioned the Tobago Health Promotion Clinic, and these slides were actually presented by Dr. Noel, Dr. Raymond Noel. The Tobago Health Promotion Clinic includes a very holistic intervention that includes mental health. Whoops, I did it, did I? I don't think so. pharmacy, lab, nutrition, housing, chaplaincy, research, social services, prevention, etc. So they tried to do a very holistic type intervention, and they actually were able to reduce mortality significantly by the kind of intervention that they were doing, and they were able to track this. So even as early as 2008, in his presentation, he showed how they had actually reduced mortality very, very significantly through the introduction of ARVs and the kind of holistic interventions that were actually being done. And in terms of adherence, they were actually able to ensure adherence, improved adherence over that period of time as well. This is actually a slide. I don't really intend that you should be able to read all of this data on the slide, but what I wanted to share with you was one of the smaller countries, St. Vincent and the Grenadines, and I got these two slides from Elliot, who is here, Elliot Samuel. St. Vincent actually, as a result of the fact that we were asking for labs to monitor their proficiency testing performance, they introduced a system within St. Vincent and the Grenadines in the lab, the public lab, for looking at proficiency test performance. And what they actually required was that at every monthly meeting of their quality management systems meeting, each departmental supervisor has to, and this still goes on, has to report on their proficiency testing. They review unacceptable reports, corrective actions, etc. So they're actually using it for corrective interventions. And this has been a direct impact of, our focusing on this as one of the indicators for the network. So just another example. So to turn to the declarations, CCAS had two declarations actually coming out of the discussions at CCAS meeting. And one of them really surrounded the importance of the lab network, that basically the participants were supporting the Caribbean Laboratory Network for HIV-related lab services, and that this network essentially is, and it still is actually, remains a part of the establishment of networks lab networks under CARFA. At the time, CARFA had not really, actually it had only just begun, because CARFA came out of CAREC, and CARFA had only just begun in 2011. And they highlighted the benefits to be gained in terms of access, cost-effective delivery, etc. And then they made a request to ministers that was taken to ministers of health when we made presentation, and through the linkage with PANCAP and CARICOM under that PANCAP Global Fund project, we were able to actually take these kinds of requests to ministers of health. The establishment of national regulations, prioritizing lab service improvements, allocating resources, supporting the development of the network through the MOUs, timely payments, and so on, because, of course, the tests have to be paid for. And the need for ensuring that ministries and customs work together to ensure that, samples are not held up. And most importantly, the one that's highlighted in red here, ensuring the development and implementation of plans to ensure sustainability beyond the donor funding. So this came from CCAS in 2011, before some of the donor funding actually disappeared. A lot of it has disappeared now, but this was really a request to ministers to really be alert to this particular potential and to ensure that this was actually addressed prior to the happening, prior to it actually becoming a reality. In 2014, the request to the ministers again was to support laboratory services, given the fact that labs really provide 70% of input to 70% of medical decisions, and only 5% of national health budgets are expended on labs, ensuring that priority continue to be placed on those national lab networks, ensuring key critical services. So beyond the lab, what else? The clinical services, the other kinds of services, support, prevention support, social services, etc., that were necessary to ensure, because we're talking about viral suppression, but viral suppression only happens if people can be retained in care, and care is a much bigger thing than giving people medication and lab services. And supporting and encouraging attendance of the groups of persons who normally would come to CCAS, because this is a very unique forum where those groups are brought together. So the country reports really serve a very important purpose at CCAS, to share successes, provide support and guidance for targets, so we agree on targets, or things that we're going to actually monitor, to monitor and track progress. The consistency of data points, of course, is a challenge, but it certainly does overall monitor and track progress so you can see progress. Generate greater understanding between different disciplines. So we have clinicians, we have lab personnel, we have social scientists. So we generate a lot more. Many times people have come and said, but we understand a lot more now about what the lab does as a result of the discussions at CCAS. We determine gaps and challenges and look at potential advocacy strategies, and that's why some of those CCAS declarations came into being. I just want to spend a few slides, because the topic was capacity building in the Caribbean. I want to mention that there were other capacity building interventions taking place that supported all of what CCAS has been doing. CDC PEPFAR, laboratory strengthening from 2009, has actually been supporting staff, equipment, and so on in some of the countries. They've been training labs towards accreditation, SLAMTA training, and they've been supporting accreditation for HIV reference labs and some of the major public labs within the region. In collaboration, PAHO, WHO with CrossQ, and CDC with CrossQ, CARFA, ourselves, accreditation bodies, developed the laboratory quality management system stepwise improvement process. We have, shared that extensively at CCAS. And this is really a process where, in fact, labs would actually have to meet basic requirements, tier 1, taking the big international standard and breaking it into bite-sized pieces that people can implement in a stepwise way. So tier 1 really is intended to be the mandatory minimum requirement, and then the other tiers would be voluntary for labs that want to go to accreditation. And having said that, I think it's really important for us to look at what has been happening with accreditation, and I have a couple of slides on that a little later. We have also been involved at CMLF with capacity building initiatives under the Global Fund Round 9 grant from 2011 to 2015, and then the recently started OECS Global Fund grant. And some of the things that we've been doing there are the network monitoring indicators, because those were developed as a result of the interventions to look at what's happening with the network. National lab network plans, provision of proficiency testing, regional framework for national laboratory policy, and development of draft national policies in several countries in the region. We're also now, under the OECS grant, doing a study to determine the barriers to lab access for key populations in the OECS countries. We're validating an algorithm, and in fact, it's one of the partners here at CCAS who is very much involved with us on that, and training for testers for key populations in the OECS. The regional policy framework is a really important element of what has been done over this period in terms of, and taking it to the highest level, the ministers of health, for their endorsement has been really important. They've endorsed it, and they requested member states, and all of these member states actually have actually developed draft policies, and some of them have actually implemented it. In fact, St. Martin just recently contacted me to say, look, we want to review our policy because it's been in place for the last 4 years, and we want to review it. So some countries have implemented the policy, many of them have not. We're looking at supporting the OECS countries as we move forward in their adoption. And the policy really is about governance, quality systems, lab support systems, and information management. So in 2015, actually, the COSOD, when we reported what had happened, they had endorsed the policy framework in 2014. In 2015, they noted and congratulated the work we'd done with countries, and they actually committed, the ministers themselves committed to provide leadership at the national level for implementing these policies, and recognizing that there was a need to address with urgency the human and financial resource needs of the labs. So they committed to that as well. The problem is holding them to the commitment, as if on time. And these are just the last few slides that share with you the labs that are accredited in the Caribbean. And there are about 27 labs. The Bahamas reference, HIV reference lab, Bahamas Princess Margaret. I'm just highlighting. The ones in red are public labs. Barbados Lady Mead, and the QEH Hospital in Barbados. All those are accredited. In Cayman, we have the Cayman Island Health Service Authority. In Curacao, we have the Public Health Lab in Curacao. Jamaica, the National Public Health Lab. Partial accreditation for some of these labs. This is what some of the labs are doing, is having a partial accreditation and not a full accreditation. So Suriname is also in the same situation, having partially accredited their public health lab. And I wanted to highlight Bermuda because Bermuda put legislation, and that's why we're harping so heavily on this issue of putting policy and legislation in place. Bermuda put legislation in place. Actually, they put a regulation under old legislation in Bermuda in 2002, and they have all their labs now accredited, including their major lab, which was accredited in 2005. So all of these others have been accredited. So CCAS really took us from the little lonely lab tech sitting, trying to do CD4s in the lab, to this wonderful network of support from many, many countries and regions of the world, and different aspects, suppliers, experts, etc. And certainly in the end, what we really want to say is we need to protect everyone. And it starts a lot with the lab. So thank you very much.
Thank you very much, Valerie. The presentation's open for questions or discussion. I'll ask a very quick one. So prevalence, and we heard this in multiple of the talks, that they can be quite variable in the accuracy of reflecting the true infection rate in the countries. For the data that you were showing, is there a uniform way in which the studies are done to collect the data that goes to Caesar and others? Yeah.
Yes. So in fact, UNAIDS has really prescribed a lot of what is reported through things like prevalence and so on in terms of identifying exactly what those indicators should have.
Yeah.
So when people come to CCAS, generally they report what the country has reported to UNAIDS in terms of prevalence data. Having said that, that doesn't mean that it's all done in the correct and same way. Yeah. But there is, we certainly coming out of the CCAS initiative did not try to identify any other way of measuring other than the way in which it is traditionally measured for the purpose of providing the data to UNAIDS.
Hi, my name is Amrel Adamson, Lady Me Reference Unit. I am trying to find out if a study has been done on the physical and mentally challenged persons, and I'm trying to find out for also those persons that may be blind, hearing impaired and stuff like that, if they are the 10% that are being lost. I'm also trying to find out how accurate is the data being analyzed if we are not able to reach these persons, if it's because of the lack of skilled or untrained persons to communicate with them.
Okay, thank you. I think that question is a little bit out of my scope because actually the whole idea here was just to give a picture of where countries are at in their interventions. And I think when the countries are actually presenting their reports, it may be useful to ask that question again. And certainly, I think Cesar may also have some comments with respect to that, where the 10% is actually being lost.
Brendan.
I think that the honest answer to Tom's question is no, data are not being collected in the same way.
In a systematic way.
And just to stop at that answer is not fair, because I think that there are challenges within countries to get access to the baseline population and therefore to know what the true incidence of prevalence rates are. And incidence rates, I don't think we've had the level of sophistication. I noticed in Barack's presentation that gains are being made in establishing what are recent infections versus long-standing.
Right.
We haven't gotten there yet in the Caribbean. As far as I know, I mean, I would be happy to be contradicted by persons' presence from any country that's doing that.
No,
So- So I'll just make a quick comment. Is Bharat here? I know he was earlier. So Bharat and I both, we have these assays that we reflex. So you test the positives and you look at the antibody development, and his assay is called the LAG assay. It really is being used throughout all of Africa. And it is amazing the data that is being generated. It's actually very easy to do. And the laboratories here, I think with Bharat's influence or others, could pick this up, and you could start seeing incidents, but it still comes back to that very important question: how are the data being systematically
Exactly.
collected, so that you then get
Exactly.
a good incidence? Yeah.
And I think, you know, the challenge with the CCAS, because these are based on CCAS country presentations, and the challenge with this is that countries actually produce the data and then report it
Yeah.
at the meeting, but there is actually no underlying evidence of exactly how it was actually collected. So most of the time they take data from their UNAIDS report, but, you know, they may not.
Right. Right.
Hi, Wayne Laversteed from Caribbean Med Labs Foundation. I just wanted to highlight some of the challenges with those indicators and the reporting issues. Many of them are complex indicators, and the countries struggle with what does this actually mean? How do we actually arrive at this particular figure? Sometimes the first time they see their data in any kind of context is when the report has already been published. And once they see it in the context, they realize, okay, well, this can't make sense. But that was the first opportunity they had to see the data in some context that they would be able to understand what they were really being asked to provide. The other thing is that the indicators change from time to time, or the definitions of the indicators change from time to time, and they just handed a new set of indicators after they've organized themselves to do it one way. It's now a new thing. And then the indicators for UNAIDS are largely based on key populations, which will not identify themselves to us in this culture, in this region. So you begin with the challenge of, okay, we're reporting on people who won't identify themselves to us in the way that the indicator requires, and where do you go from there? So there are many challenges with, you know, getting to what is expected.
It is. Thank you. John.
Yeah, very short comment. I think that the way that the lab reporting has been done for the past, 20 or some years, you know, moving from just prevalence to now treatment or access to treatment, resistance and so on, of course, makes the report more and more complex. We try to make an emphasis every time that the reports, it's not UNAIDS. I mean, we were happy to collate and put it together, and there is this global group that it's the global monitoring group that comes up with the updated version of indicators and so on. And nothing would please us more than seeing countries use their own data into decision making. As I was saying earlier today, unfortunately, when we do the estimates exercise, and that happens every 2 years, when countries come to the table with the computers to run the spectrum model, it's basically the same data that we used 2 years before. And it's like, I don't know, forecasters need several points, right, to try to see where things are going. When you only have 1 point, you can tip it either way, and so we're not responding correctly. I feel that also we have imposed more and more demands for data. It should be simpler.
Yes.
And that's a mea culpa on behalf of the institution at the same time. Now, it used to be the reports came out every 2 years. Now, then the reports were coming out every year. And now we're asking countries to report every 6 months. Now, if you listen to all of the presentations that we have listened in the past couple of days, it takes time
Yeah.
to collect the data.
Not
to
just time,
generate the
but
reports.
resources too, eh? Human
Resources and
resource.
effort. So, I mean, I have had people who come, I don't want any more questionnaires, I don't want any more forms.
Exactly.
So let's try to, I like your approach, Valerie, and if we in the Caribbean, as also you were recommending, Tom, could come to a, simplified way of
Yeah.
looking at things, a standardizing a bit
Yeah.
more. That's just my comment. Thank you.
And I think there's a particular difficulty with
Thank you.
spectrum with the small countries, the very small populations where spectrum really just doesn't work.
Great, thank you very much,
Okay,
Valerie.
thank you.
This
Thank
concludes
you.
your presentation.